Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
Well, welcome. This is our first podcast, Conversations with Jeff and Christine. And we are just delighted to be here. And we are going to kick off this podcast series talking about ADHD and hopefully keep your attention by doing so. Jeff, ADHD, and I think quite honestly, I'm going to learn from you as we sort of debunk this topic. And certainly from my perspective, this is one of the hot topics where patients come into your clinic and it's a laundry list of items. And this becomes the last item on the list, the doorknob you're about to leave. And the patient's like, I think I have ADHD. I did an online quiz. What are we doing with this? And where are you going? What resources are you looking? We have a jam-packed session.
All right. I'm so excited to be here. Episode 1.
Yeah.
I want to point out, we recorded an intro episode this morning, and you had the wherewithal to go change for episode 1, whereas I didn't change at all. So I'm wearing the exact same shirt, and I'm proud of that. So welcome. And we are very excited to be here. You bring up a good point with ADHD, but I think for me, the most important thing is I can't tell you how often I get a text message or email. Yeah. Where do you refer for ADHD? And I find that astonishing. I mean, I never get emails saying, where do you refer for hypertension or where do you refer for diabetes? I mean, ADHD is a primary care illness. I think it's something we all need to deal with. And I understand we're all busy. We know that our average visit is 9 minutes. How could a family doctor do this in 9 minutes? And exactly like you said, it's the hand on the door phenomena. Oh, I think I may have ADHD. But I think it's something we can deal with fairly easily. We just have to be more comfortable and learn. It's really, really common, as you know.
Yeah. So, Jeff, you come from an expertise in mental health. Hence, you're sort of taking the leadership for this podcast right now. But, it is confusing for the run-of-the-mill family physicians. Some of the medications come with warnings. And, so what I think we need to do is give a roadmap. A patient comes in, I'm going to say adult, right? Because that seems to be the trend as of now. I think I have ADHD. Go, Jeff. What do you do?
First of all, let's tell you how common it is. We say 5 to 9% of adolescents and kids have ADHD. That's a ton. Think of those numbers. And 3 to 5% of adults have ADHD. So I always say, let's say 1 in 25 adults has ADHD. And people always ask, do you outgrow ADHD? We don't actually think you outgrow ADHD, but you may outgrow the DSM-5 criteria for ADHD. So the first thing I do is I make sure it's not the last thing they say. And if it is, I have no problem addressing it all. And I'll say, hey, Bob, you know what? I think that's really important. Let's set up an appointment. My ADHD visits are always dedicated visits, 100% of the time. So I will never do ADHD and diabetes or ADHD and an ankle sprain. They think they have ADHD. I think they have ADHD. Let's set up a visit. And I'll prepare for that visit. Like I'll give them things to answer before that visit. And we can talk about that.
You mentioned some stats and certainly the ruminations that I've been having is, there's a gender difference too. I think notoriously females are underdiagnosed for a wide variety of reasons. And I've certainly seen several women in their, let's say, 30s to 45s that have come in and sort of said, in hindsight now, I think that, school was difficult, but I compensated. I just want to emphasize that because I think traditionally females have been forgotten in ADHD treatment just because of different compensation mechanisms. Would you agree?
I think that's so important. Yeah. You're right. And we report that it's 2 to 1 males to females.
Yeah.
But I agree with you. I'm not sure that's accurate. And the reason is, picture this. So you're in grade 4 in public school and little Johnny is on top of the desk and he's dancing around and he's the class clown or he's blurting out. And little Sonia is sitting in the back daydreaming quietly. No one even knows what she's doing. She may be thinking about her garden from the day before where she was gardening with her mom. It's a very different presentation with little boys and little girls. And you're absolutely right. They're often missed. So is that 2-to-1 accurate? I'm not quite sure. But the one thing that's accurate is the genetics of ADHD. And we always look backwards and forwards. I mean, if you have a parent with ADHD, there's a 65% chance their kid has it and vice versa. So if I diagnose a kid, I'm always wondering which parent has ADHD. And I mean, with siblings, concordance of a 33%, but I'm always looking because I know it's there. If you have a parent or a kid with ADHD, look forward or backward, you'll find more ADHD.
I think that's a clinical pearl. Instead of when the patient traditionally comes in, you take a family history that precedes the patient and sort of do your diagnostics. And with ADHD, I find I'm asking about their kids, whether they're my patients or not. Another clinical pearl. Okay, so Johnny has come into your office, end of the consult. He says, I think I have ADHD. You very, very compassionately say, let's dedicate a second appointment for this. He comes in. What has he done before us? What scales are you using? Have you sent him to any websites?
Yeah, it's a great question. So first of all, let's assume Johnny is, how old do we want to say he is?
I'm going to say Johnny's just 41.
I mean, a little late, but we definitely see them. And inevitably, I can tell you about Johnny. Johnny's had multiple jobs, and that's a pearl. People with ADHD untreated have multiple jobs. Like they go from job to job to job. Their self-esteem is low. They don't hold a job. Often they've had marital or relationship breakups. They've been struggling through life. Like they've been having a hard time. And the one thing that Johnny will tell you about every single job, my boss is this or my boss is that. They hate every boss because they don't get along with people at work. They are struggling. So we'll talk a little more as we go on, but to diagnose ADHD, I'll use DSM-5 criteria always, and I have a stamp in my EMR, but I'll use a scale. Like for an adult, I'll use an ASRS, and in my case, I'll send it ahead of time. I use Ocean to send it, but you can use ADHD rating scales. You register, the patient registers, and you can get an ASRS that way. But as we're going to discuss, there are always, we say 90%, but comorbidities in ADHD. ADHD does not travel alone. That's probably the biggest pearl I can say. So when I'm throwing in the ASRS, I'm also going to do a PHQ-9 and a GAD-7. I may do more depending on the flavor because maybe it's not an apparent comorbidity. Maybe the comorbidity isn't anxiety or depression. Maybe it's substance abuse that I don't know about. Maybe it's an addiction that Johnny's never shared with me. It may be a secret addiction. It may be a porn addiction. It may be a drug addiction. But generally, always keep in mind there is something else when you diagnose ADHD.
Another clinical pearl. The other thing is sort of asking about, vital signs. I like to call it a vital sign check. Are they, getting sleep? Are they, caring about their nutrition? I know it sounds pedantic, but a number of patients, to a certain extent, and may not be the only solution, tidying up what you do or don't do during the day is quite helpful and certainly part of the long-term treatment. Okay, so Johnny, he's in, he brings his scales. Let's say, he definitely has signs of ADHD, no substance abuse concerns. The other scales are moderate, maybe a bit
or
of
not,
anxiety.
or I didn't
not.
find it.
Yeah. So how are you initiating this discussion? Because he comes in thinking, he's filled out every TikTok and
Right.
Instagram scale possible.
But it's interesting. The question is, what brought him in? Like, did his partner, did his best friend, did his parent? I mean, I bet you what happened is Johnny's 41. He's had multiple jobs. He's struggling. He's probably just gone through a marital breakup. And Johnny's 14-year-old kid just got diagnosed with ADHD, for sure. And Johnny's thinking, oh my God, okay, like my son Bobby has ADHD, and I think I'm a lot like Bobby. So that, I mean, suddenly to bring him in at 41, that would probably be the most important thing. And the one thing I think it's very important to do with people with ADHD is to reassure them it's not their fault. It's a physical, biochemical illness in the brain that actually causes brain changes. Especially the kids have smaller brains. And I talk about the importance of ADHD. I mean, we know people with ADHD have, especially as kids, increased accidents, increased ER visits, but they have increased criminality. They get more traffic tickets. They get in more motor vehicle accidents. The one really impactful thing that I know we've discussed in the past is they die more often prematurely. Like, it's not a benign illness. And we can really change their life by treating them.
Absolutely, right? And I think a lot of when, patients come in later on in life, there's a sense of frustration may not be the right word, but regret that they've, lived, in Johnny's case, X number of decades and have struggled without anybody actually reaching out, without anybody saying, "Wait a minute, something's off." So I find that that's something that you need to deal with too. There's I would even use the word anger, not necessarily directed at us as clinicians, but just anger that, life could have been a lot easier.
And the one thing we didn't talk about that I think we need to is in DSM-5, we need to corroborate that these symptoms started before the age of 12. So imagine 41-year-old Johnny, he's looking at me and saying, I have no idea if they started before 12.
Yeah.
Did you have trouble in public school? Did you get in trouble a lot? Did you get detentions? Did you get sent into the hallway? And if Johnny doesn't remember, we need help. We need to ask Johnny's brother. We need to ask Johnny's mother if she's around, or Johnny's aunt. Someone needs to remember, and I really want to corroborate that these symptoms started before the age of 12. Would I not treat ADHD if I can't? It's tougher. Because I don't want to see someone who comes in at 41 and swears that these symptoms started 1 year ago. If these symptoms started at 40, they do not have ADHD.
I mean, I think too, though, as part of the clinical, evaluation, people if they find it hard to think back. Johnny may not correlate his constantly changing jobs. I mean, he's had terrible bosses. Every single boss has been terrible, right? So I find that those initial interviews are a bit difficult, right? It's hard to think back and sort of correlate mishaps, a missed marriage, problems with their family, it moving all the time, too many traffic tickets, and dedicating. I really liked your point that you bring them back and dedicate a specific appointment to it, because there's a lot to discuss. It's not often pleasant either.
Right. And I mean, I help them exactly like I said. I try and probe them. I say, like, I want to bring through behaviors that I would expect to have seen in public school and different for little boys and little girls, as we discussed. But I want to remind Johnny, did you get in trouble? And he may say, you know what, I never got in trouble and I did very well. But there are things. Then I'll probe him. Did you procrastinate? Did you hand in your assignments on time? Were you late for things? I mean, you want to get those symptoms out, and hopefully they started before the age of 12. And we talked about an ASRS for big Johnny, but remember, for little Johnny also, we have a SNAP, right? If we're going to diagnose. And the way we do a SNAP for kids is we give a SNAP for the parent to complete, and we give a SNAP for a teacher to complete. And we reassure everyone that it doesn't take a long time. And it's interesting because now in early September is not the time to give a kid a SNAP. The teacher has to learn what the kid's doing. And I generally won't do SNAPs now until late October, November. I want the teacher to really get to know the kid.
And I think, just speaking about the younger patient, I always emphasize that, of course, you don't want to give this scale in the middle of September. I get that, but sooner than later, because I've certainly found myself in circumstances where, people look back, there may be a diagnosis and you're scrambling to get certificates that then cost quite a lot. If they haven't had appropriate academic accommodations, at some point that's going to catch up to them. And to backpedal and try to make a diagnosis with a certificate that's, accepted by a university is a bit of a nightmare and just stressful. Emphasizing that, yes, we don't have to be panicky about it, but, early diagnosis with proper treatment, proper supports is absolutely imperative.
And not all people with ADHD also have struggled academically.
Yeah,
They've gotten through. I mean, we know physicians with
correct.
ADHD. I mean, that's my favorite. I mean, I can't think of how many ADHD talks I've done where physicians have self-diagnosed and have come back to me years later and said, "Oh my God, my life changed after your talk because I have ADHD." And I'm thinking of some very specific examples. So it's very interesting. Also, remember that the symptoms of ADHD present very differently in little Johnny versus big Johnny. Little Johnny may have more predominant hyperactive symptoms that will fade over time, but the inattentive symptoms stay steady. They're always there. But so the hyperactivity goes down as the child ages. And interestingly, the comorbidities will appear in adolescence or adulthood. So you're not necessarily seeing the comorbidities in 7 or 8-year-old Johnny. They may come at 12 or 15-year-old Johnny.
You've had this conversation with him and, symptoms started before he was 12. You're pretty sure that he's actually bang on. Um, next steps.
I
Next
mean,
step, Dr. Habert.
next steps like we do with any chronic, and I'm going to emphasize this is a chronic illness. And we love when patients ask us, how long do I take this medication? And the answer is we take it for as long as we need it, but it's a long-term medication. And we can talk about not meant to be used only when you're working or in
Yeah.
school and meant to be used 7 days a week. And like we do with every other illness, let's start with pharmacotherapy interventions, psychosocial interventions, psychoeducation. What is ADHD? What can we do? Can we get specific CBT for ADHD if they can access that, which is hard? Can we get them vocational counseling? I mean, Big Johnny certainly could use vocational counseling. If they can afford it, if they have access to it, we'll do that. Assistive technologies, just one. And I can't emphasize enough the smartphone. Every single Johnny that sees me has a smartphone. And I will teach that the reminder app on his smartphone is his new best friend. That reminder app is going to remind him that he starts work at 9 o'clock, that he's meeting with his boss at 10 o'clock, that he's got an assignment due tomorrow. That reminder app should be ringing all day long because it's a real helpful thing. And for little Johnny, we've seen the sticker calendars and the things that the parents do to reward. But Big Johnny needs to be burning that iPhone or that Android phone with his reminder app. So first, non-pharmacologic.
Setting up systems, I think, to increase this chance of success of remembering appointments. Bang on. Yes, counseling, vocational, that is, the goal. Finances are a problem. Resources are slim. I find that Cadra is one of the best websites in terms of any chronic disease, Canadian based, filled with information, not only for us as primary care providers, but resources for patients. They can access the scales. They have hyperlinks to really, really excellent online therapy, group chats. And, I think that's one of the top resources I share with patients, even before they come in for a formal diagnosis, just to peruse, because there are some excellent opportunities to do DIY and not necessarily have to pay for it.
I agree. I mean, I think that's really, really, really important. So we've gone through the psychoeducation, assistive technologies, explaining what the illness is. Then we talk about pharmacotherapy. I mean, foundationally, it will work. It is life-changing. And the one thing I do before I start the pharmacotherapy, and we have two choices that we'll talk about, is I tell them that these drugs are safe. There's a lot of stuff out there on Google, and we're hearing everything, and everyone's got ADHD, which is not true. These drugs are safe when used responsibly and remarkably effective fast. And the few things I'll say is there are no cardiovascular issues we really have to worry about. We do not need to get an ECG, but I do need to monitor weight and blood pressure. So I always get a baseline weight. And an ADHD visit, the first one, is never something I will do virtually. They need to be in the office. I need to take their pulse, their blood pressure, their weight. I really want to see them. Stimulants can slightly increase their blood pressure and pulse. It's not usually an issue. And if we look at the choices, there's only two. It's quite easy. We're either going to use an amphetamine-based stimulant or a methylphenidate-based stimulant. And if you're asking me which one I choose, it's 6 of one, half dozen of another, because we don't actually have evidence that one is better than the other. And we have the rule of thirds, where a third of people will respond better to amphetamine-based stimulants, a third of people will respond better to methylphenidate-based stimulants, and a third will respond equally well to both. And if they don't, you switch it. I mean, they're so remarkably effective that the number needed to treat for these groups of drugs is 2 to 3. I mean, that's an insane number if the diagnosis is correct. But as we've just shown, it's not rocket science. If I can do it, everyone can do it. You just need to learn and be comfortable.
And how often are we seeing Johnny for vitals
It's a great
check?
question. So I pick whatever stimulant I'm going to use, and I'm going to start them. So typically for me, the magic spot for most of these drugs, there are exceptions, is 40 to 60 milligrams, whether it's methylphenidate based or lisdexamfetamine. I'll start them at 20, 25, 30, depending on which drug I use. And I'm raising their drug every 1 to 2 weeks. So I typically, day 0, I'll prescribe a couple of doses. And then I'm usually seeing them 3 to 4 weeks later. And they've escalated the dose on their own. So I've given them a prescription, let's say, for 3 doses. So let's say I'm using a long-acting methylphenidate like Foquest. I'll give them a week of 25, a week of 35, a week of 45, and I want to see them before the end of that 45 week, because in my head, for that specific drug, I know my magic spot is, let's say, 45 to 70. For lisdexamfetamine or Vyvanse, my magic spot would be 40 to 60, maybe a little lower for a child. But I think what we need to do is not stay at lower doses. Like, you can't, and I've seen adults, the doctor is hesitant, he puts them on 20, they come back a year later on 20. 20 is just not going to be an effective dose for the adults. So I titrate up until we see the desired effect, and then you're going to say, well, what does that mean? That's tough. So if they're in school or university, it's easier because their performance at school or university will do better. Marks will go up. They'll be doing better. But for our patient, he's going to measure it in terms of getting along better with people at work, keeping a job, performing well at work, performing well in relationships and with his children, increasing his self-esteem. So you're looking for gains and goals that I set with the patient at the outset. What do you want? What do you want them to do for you?
That is brilliant. And I do that often in other mental health states. Scales are wonderful, but it's hard to think back. So the first visit, 5 goals that would tell you you're doing better. You write them down in the chart. And when they come back, you ask them. And sometimes patients are astonished and say, wow, I'm actually doing better or not. I think that's a huge clinical pearl.
And then, so if I'll see them till I get a desired effect, if they respond, that's great. If they don't, I'll switch to the other family. So if they're on amphetamine based, I'll go to methylphenidate and vice versa. And the biggest side effects are common with both sets of drugs. I mean, we worry about weight, especially in young girls that I treat for ADHD, like 12-year-old girls that start off at 90 pounds. I'm not so keen on them losing 10 pounds. So I monitor weight. I ask them about sleep, because appetite changes and sleep can be the biggest side effects. But it's interesting in adults, especially now that we're using longer acting stimulants. I mean, whether it's Lisdex or whether it's long acting methylphenidate, we're using drugs that are lasting more than 12, 14, sometimes 16 hours. I find most of my adults sleep better because I'm turning off their brain at night, and people worry, you're giving me a drug that lasts 14 to 16 hours. Am I going to not sleep? And the answer is you're going to sleep better because you're not lying in bed at 10 or 10:30 at night and worrying, or your head is spinning. You're thinking about a million things. It actually turns it off. And the other thing we've changed is you want to use longer acting stimulants. You may think the guy, so I have a patient actually who was pumping gas. I saw this guy 10 years ago. Struggling. He pumped gas. His wife was a factory worker. They had 2 kids. The grandmother took care of the kids during the day. And this guy was on a short-acting methylphenidate because the doctor felt that was enough because he worked 8 to 4. But when you ask him, this guy was struggling at night at home with his wife and children. He just was not performing and couldn't do what he needed to do with his family. He needed a longer acting stimulant. So always keep that in mind.
That's a great story. And I mean, following these patients, I think it's one of the most rewarding conditions to treat, to be honest, because the medications are effective and you see it when they come in. Final notes, just some top of mind, 2 things you want our listeners to take home.
So, I mean, one thing is this is a chronic illness that is quite common and safe to treat. But I think most importantly, Christine, the 2 things is ADHD does not travel alone. And look close if you have someone with ADHD because someone else in their family may have it or likely has it.
So thank you to our listeners, and we hope that we kept your attention during this session. And we look forward to hopefully having you listen again for another podcast, another topic, and another outfit change.
That was a lot of fun. Thanks a lot.
Ciao, ciao.